चार्जिंग तो ते दाबलं अच्छा स्लीपमध्ये गेलं मग ठीक आहे दाबायचं तेच होतं हां आपण करूनच ठेवलेलं पॉज कर नको Good afternoon, everybody. Since morning, we have heard a lot about relative stability and absolute stability. I'll be talking about the lag screw, which follows the absolute stability principle. I would like to know from your side, how do you do it? How do you put the lag screw? What are the steps you follow? Anybody, if you could describe the steps. We do it routinely, right? So anybody who can describe what all steps you follow while doing the lag screw? Precedence? Nobody? CPR precedence? Nobody does the lag screw or nobody does it properly? If you make mistakes.
And then I'll pass this to.
Right. So this is the correct method that we follow. What you said, if we do it that way, then what we'll get is a position screw and it will not compress the fracture site since your screw is holding in both the cortices.
Rather than calling this as a distal and proximal, the near and far.
Far cortex, yeah.
That will be more easy to understand. Near cortex, which you are looking at, and the far cortex, which you are not looking at. So if you use that terminology, rather than proximal and distal.
Now, what you said, we'll be using 2.5 drill bit, the help of sleeve. Okay. We use a 3.5 tap.
Very important is gliding hole you should make first, not the far cortex. Near cortex first you should drill with the same size, and then purpose is your screw is not going to have any purchase in far near cortex. Only purchase in far cortex, and the screw head, when it goes and touches the bone, it will start pushing it down. Now what he has done with 2.5, he has drilled both the and tap, and now he is doing putting the same 3.5 mm screw. So what you are expecting now, what will happen to that gap? It will not collapse now because this is a wrong technique.
So now when I
Positional.
tighten,
However he tightens, the head will not.
this gap is not going to close. So this is completely tightened and you can see the gap is still there. This is because the screw threads are holding in both the far and near cortices, and that is why it is not able to compress. The head is not able to compress. The right way to do it would be, We use a 3.5 drill bit first. Drill the gliding hole. Drill bit change. We use a 2.5 drill bit next. We put the sleeve inside this. We have to put it inside the bone so that the direction of this doesn't change, right? Otherwise you can give it direction in whatever manner you want. So you put your sleeve inside, stays inside.
When you have got to,
then you drill the far cortex with 2.5.
when you have got a big butterfly, so AO has one technique where you keep the butterfly means away, drill first far cortex, then they have got one aiming device that goes and locks the far cortex, and then you reduce the fragment and drill the near cortex.
30, sir. And now while tapping, we push the tap inside first and just tap the far cortex, not the near cortex.
As now hole is of same size of tap, so far cortex it cannot tap only because it is totally same size. It will not have any purchase. If your plate, which is going to be a protection or neutralizing plate, is going to come above the screw, then you have to countersink this screw.
Bas, huh? So that's the countersink. You just put it here and rotate. Remove some part of the cortical bone. It should not go in, otherwise your head will also sink in and will not achieve the compression. And just see, the screw has gone in directly, and now it will start engaging with the far cortex, and slowly the cap will start.
The moment head touches the bone, the compression will start.
Right? So now it has compressed. This is because the far cortex is free and the screw can easily glide through it. Now positioning the screw perpendicular to the fracture is very important. If you position in any other direction, then there will be shear forces, and that will push that fragment. If the reduction is like this, it will distract that fracture site, right? So positioning it perpendicular is very important. What all screws can be used for lag screw? You can use cortical screws of 3.5, 4.5, dependent on the fracture. The 6.5 screws that we use for proximal tibia fractures or neck of femur fractures proximal tibia fractures can also be used as a lag screw, in which you drill the hole with 3.2. The screw thread diameter is larger and the shaft is thinner, so it automatically acts as a glide hole. You will have to drill and tap the near cortex and not the far cortex. You do not pierce the opposite cortex in that. And then after measuring the length, you tighten with the help of washer, because the near cortex will be very thin and the head will go in. So you put a washer and achieve the compression there. So that screws also can be used as a lag screw. We'll just go through the video and stop. इससे HDMI होता है उसका. volume.
cortex screw will be applied without a gliding hole to function as a position screw. By over-drilling the near cortex, interfragmentary compression can be obtained. A 6.5 millimeter cancellous bone screw is used to demonstrate interfragmentary compression of a medial tibial head fracture with a lag screw. Conventional plating with the LCP, or locking compression plate. The 4.5 5.0 LCP is used as a standard compression plate and as a compression plate with a lag screw through the plate. Then there's the LCP L plate, which is a buttress plate. The screw technique. The standard 4.5 millimeter cortex screw below and the 6.5 millimeter cancellous bone screw above are used in these exercises. The 4.5 millimeter cortex screw has a thread diameter of 4.5 millimeters and a core diameter of 3 millimeters. The 6.5 millimeter cancellous bone screw has a thread of 6.5 millimeters and a core diameter of 3.2 millimeters. It's available with a 16 millimeter thread, a 32 millimeter thread, or fully threaded. The following instruments are required. The 3.2 millimeter drill bit, which is slightly larger than the core diameter of the screw, and the 4.5 millimeter drill bit, which is the same diameter as the thread of the screw. The 4.5 3.2 double drill guide. The countersink. The depth gauge. The 4.5 millimeter tap for cortex screws and the T-handle. And the large hexagonal screwdriver. The generic bone is fixed in the bone clamp. Using the 3.2 millimeter drill bit and the 3.2 drill sleeve, both cortices are drilled through, perpendicular to the fracture plane. The depth gauge is used to determine the required screw length. The thread is cut using the 4.5 millimeter tap and the corresponding sleeve. The 4.5 millimeter cortex screw is inserted. Compression between the screw head and the bone surface is obtained, but as both the near and far cortex are threaded, the
cortex both, and so it is not compressing. Now here in lag screw, the upper part has no threads, so it just slides, and then now it is started engaging in the far cortex. And so when you tighten the screw, the head will push that part of near cortex towards the far cortex. Thus he is using 4.5 mm drill bit, drilling the near cortex. Now you put a 3.2 mm sleeve inside it and drill with 3.2 mm the far cortex. He is using the countersink so that the prominence of the head of screw is not felt, or in some cases the plate is just overlapping and put the plate comfortably over it instead of getting deformed, or in tap of 4.5 for tapping the far cortex. Now when it tightens, it's engaging the far cortex. Once the threads, the head starts pushing the near cortex towards the far, and you achieve the compression at that side. this is what I was talking of. If you do the technique correctly but the direction is wrong, then shear forces will act and the fracture will get displaced. Even if all the technique is right, since the direction is wrong, the fracture is getting secondarily displaced after the reduction. Same for the 6.5 mm, is drilling the near cortex with 3.2. Measuring the length. Using a 6.5 tap the near cortex and not completely. And the screw with the washer. This is a normal DCP with combi holes, locking hole.
Direct HDMI ला आणि तिथं व्हायला. हे काढलं की येतंय.
यूट्यूबला
हाँ yes ते लाईव्ह चालू आहे सो विल हॅव टू रिमूव्ह दॅट. मला वायफाय कनेक्ट करून दे. HDMI दे ना मला. VGच्या जागी डायरेक्ट HDMI दे. अच्छा अच्छा होत नाही आहे.
Hello?
So till that time, what is the indication for positional screw? There are two. One is the latch screw, another is the positional screw. So where you will use the positional screw? Sim test is okay. Sim test is just after reduction, after applying the clamp. Okay. Anything else?
तिथे माईक ठेव.
So other indication is when
Collarless
you are
mic.
doing intra-articular fracture reduction and it is a multi-fragmentary and if you use a compression screw that will reduce the articular surface area. So after reduction in a multi-fragmentary intra-articular fracture to maintain the length of the articular surface to match the opposite surface. After reduction instead of latch screw you have to use a positional screw or you can also use the LC locking head screw after reduction. That will also act as a positional screw.
फोन आहे ना सरांकडे कनेक्ट VG वाला.
The insert therefore remains flush with the outer sleeve. Alternatively, by pressing the drill guide down against the bone, it will be centered in the compression unit of the combination hole. In this neutral position, no additional movement or compression will result from screw insertion. The spring-loaded insert now protrudes from the outer sleeve. With the drill guide in the neutral position, A 3.2 millimeter hole is drilled through both cortices. The depth gauge is used to determine the required length. The thread is cut in both cortices with the 4.5 millimeter tap. The soft tissues and the plate surface are protected with the appropriate protection sleeve. A 4.5 millimeter Cortex screw is inserted and tightened. The second half of the bone is reduced and fixed to the plate with the bone-holding forceps. Without applying any pressure to the universal drill guide, a 3.2 millimeter eccentric hole is drilled. The length is measured. When driving home the screw, the head hits the smooth slope of the plate hole. The bone is moved axially, creating compression of the osteotomy. However, this compression occurs only beneath the plate in the near cortex, while a slight opening of the osteotomy in the far cortex can be observed. Here the point is illustrated. The widening of the gap in the far cortex can be avoided by overbending the plate, like this. To begin, the screws and the plate are removed. The plate then is slightly overbent with the bending press. The same osteotomy is now fixed with the overbent plate and the screws. For optimal compression without loss of reduction, it's recommended to sequentially tighten the screws. The gap is now closed, and the bone is compressed over its entire cross-section. A stable and anatomically correct internal fixation has been achieved. In this exercise, the function of a compression plate in combination with a lag screw
very self-explanatory video. What is very important is, this is a LC. Very self-explanatory video. What is very I'm not going to demonstrate it because there is no fractured bone over here. What is important is pre-bending of the plate. Now, if you don't pre-bend the plate, what will happen is opening of the far cortex. And remember, this especially happens when you are doing humerus fracture in lateral position, because you are not able to assess the lateral reduction properly. Because getting a lateral reduction is very, lateral imaging is very cumbersome. So please pre-bend the plate so there is no opening of the far cortex. Another thing which is important is this particular instrument, which is known as an universal guide. Now, when we were using it, we were not using this universal guide, but those color-coded guides, but the purpose remains the same. When you use it without pressing in the hole which is designed for the non-locking screw, okay, it centralizes, okay, and when you press it, okay, when you hold it without pressing, you can take an eccentric position, sorry, and when you press it, you go in the center position. So first you put the centric screw, after that put in your eccentric screw, and then gently tighten it. That's all to it. Another thing what sir had already mentioned initially, that this is a combi hole plate. Again, it has got cutting edges beneath, so that your interface with the soft tissue decreases and your footprint on the bone decreases for better periosteal blood supply. Sir, here. On one side you put it na, you get a compression of 1 mm. So if you have a distraction which is more, you can always compress it on from both sides. But at the same time, what you need to do is you have to use 2 screwdrivers and simultaneously compress it. Okay, but those are very rare occasions. What is basically, what most commonly is done is tightening on one side so that your fractures come as close as possible. Important point to be highlighted is pre-bending of the plate. Very, very critical. Okay.
Now we will be discussing mainly about PFNA 2, but before going into that, I would like to go in the basics again where it is indicated. To understand the universal problem regarding treating the intertrochanteric fracture, one has to study and understand the fraction of personality. If there is a mismatch in choice of implant, you would end up somewhere close to this. There are so many implants we use, intertroch, subtroch, stable, unstable, all the things. Just I would like to again revise because they are really important. If you do not want to end up in such a difficult position, then you should understand the fracture geometry and classification. This understanding guides us to manage proximal femoral fractures appropriately. All of you know the forces acting to lead to instability. Boyd and Griffith classification is well known to every one of you. Stable and unstable fracture. So basically, any one of you, what is unstable fracture? When you see a patient with intertrochanteric fracture? Come on, students, anyone? No, you have seen the X-ray and you are going to plan. So reduction is a long way. Yeah, so posterior, so lesser trochanter, where it is most important. Loss of medial support or separation of the lesser trochanter is combination of posterior medial cortex, fracture of the greater tuberosity. And what is reverse oblique? Which one of this is reverse oblique fracture? This one or this? Yeah. So basically there are different classifications, reverse oblique and AO classification. I will not go in details of that. Patients need is to return to normal as early as possible. And as a surgeon, we want a fracture implant assembly that withstands the load of weight bearing. Direct full weight bearing should be possible because majority of our patients are old age people and training them to walk with partial weight bearing is very difficult. The moment they stand, they will be taking full weight bearing. There were lots of implants. I will not go into the details of the history, but the newer implants take care of mechanobiology of the fracture, and that is the most important thing of the fracture personality. So extramedullary implants like DHS with additional plates and intramedullary PFNA, this is a regular PFN and this is the intertan where we compress through one hole only both the screws go. So implant selection will depend upon all these things. I will not, this is one of the meta-analysis. No difference between PFNA and DHS in stable fractures. But the moment it is unstable fracture, the things changes. So PFNA has the following advantages: higher cutout resistance in osteoporotic bone, reduced duration of surgery, less overall complication rates, less post-operative fixation failure rate, decreased surgical trauma and blood loss, less infection rates and less wound complications. If done properly with all the principles, you can literally do a PFNA with 10 to 20 cc blood loss in 20 minutes and patient can start walking same day evening, and that's what easily possible if done properly. So in PFNA can benefit peritrochanteric fracture patient with less blood loss and fewer complications compared to DHS. As per literature, lateral wall comminution is another consideration while treating dynamic hip screw. In the presence of lateral wall comminution or iatrogenic lateral wall fracture, it is favorable to use intramedullary device. I will not go in details of this. Sorry. So, what is important is mechanobiology of implants. As D decreases, chances of implant failure decreases. Since it reduces lever arm, the moment the D is reduced, the lever arm is reduced, responsible for calcar strain. The bigger the lever arm, strain on the calcar is more, and also because of proximal massive size of intramedullary device distributes the force of femur shaft to the tune of 93%. Biomechanically, DHS cannot control rotation, medialization and varus collapse. Intramedullary nail acts as a central pillar against medialization. Intramedullary nail is a single load carrier with a blade and higher resistance to femoral head migration. Intramedullary nail causes less calcar strain as compared to sliding hip screw. Biomechanically, the intramedullary nail is more stiffer in torsion and bending forces than sliding hip screw. It shows that when the implant in the neck and head is centered in both AP and lateral views, that is labeled as head-neck equilibrium, then the forces acting on the implant have a torque of 0. So when center in AP and lateral, head-neck equilibrium is achieved. All these details we will see in the video basically. Just like to show. So again, tip apex distance, TAD, as all of you know, in the AP and lateral, this distance from the apex of the head. So it is not here to here, it is here to here. Calculations of tip apex distance, distance from the tip of implant to apex of the femoral head on the AP and lateral views are summed up. TAD less than 25 should be achieved. So you will have to calculate in that way. So we will be seeing in the video there are two short and long intramedullary nails. Stable fracture AO type up to 2.1 laser trochanter intact excessive femoral bowing, you should use short PFN. When unstable fracture, laser trochanter is displaced fracture line extending to subtrochanteric region and AO type 2.2 onwards, osteoporotic bone, metastatic lesion, pathological fracture, rheumatoid arthritis, you should use longer video.
Here, the small PFNA will be used. The PFNA is a cannulated nail. Within its upper third, a lateral bend of 6 degrees makes it easy to introduce the nail into the femur. The PFNA blade is inserted into the femoral head through a hole in the proximal section of the nail. Due to the helical shape of the blade, the cancellous bone in the femoral head is compacted. which provides better purchase, especially in osteoporotic bone. Distal locking, either static or dynamic, can be achieved using the distal hole in the nail. The objectives of the exercise are to understand the clinical indications, pre-operative planning, the opening of the femoral shaft, the insertion of the nail and blade, distal locking, and since the PFNA is available with different CCD angle, injured leg is determined with the radio. The appropriate distal PFNA diameter is found by placing the radiographic ruler over an AP radiograph of the isthmus of the ipsilateral femur shaft. If the one image intensifier C-arm is needed. The leg is pulled along its longitudinal axis of the greater trochanter, in line with the longitudinal axis of the femoral shaft in the lateral view. The fascia is opened with scissors, and the gluteus muscles are split in the central axis of the femoral neck. The entry hole for the PFNA should be created manually, so the following instruments are used. The universal chuck with T-handle, the 3.2 millimeter guide wire, the 17.0 3.2 millimeter drill sleeve, the 20.0 17.0 millimeter protection sleeve, and the 17 millimeter cannulated drill bit with or slightly lateral to it, at an angle of 6 degrees to the longitudinal axis of the femoral shaft in the AP view.
So importance is entry, and for that the nail has, the way they have shown is a 6-degree angle has been given, and entry should be done through greater trochanter or even slightly lateral. So that is very important.
The guide wire is inserted into the medullary cavity to a depth of at least 15 centimeters. In the lateral view, the position of the guide wire has to and in the center of the medullary cavity. Any other position would place the PFNA either too ventrally or too dorsally, which would hamper the smooth introduction of the nail and impede the blade from being correctly positioned in the femoral neck. In younger patients with strong bone, it might be necessary to use the compact air drive. First, the protection sleeve and drill sleeve are slid over the guide wire. First, the nail is mounted onto the insertion handle. To do this, putting the PFNA blade through the insertion handle. With the hammer on the protection shield of the insertion handle may be used. To help determine the correct nail position, a K-wire has been placed anteriorly outside the femoral neck to indicate the position of the guide wire for the helical blade. The correct position of the nail is reached as soon as the K-wire projects into the center to the insertion handle. Color codes on the aiming arm, buttress nut. The 16.011 protection sleeve. Sleeve assembly is advanced through the hole in the aim as the precision of the insertion handle and sleeve assembly would be impaired. The drill sleeve is turned to allow the protection sleeve to pass through. The trocar is removed. A new 3.2 millimeter guide wire is introduced through the drill sleeve into the bone. Both the direction and position of the guide wire are verified with the image intensifier in the AP and lateral subchondrally into the femoral head to a point at least. Therefore, approximately 10 millimeters are subtracted from the measured length, at least 5 millimeters from the joint. The length for the guide wire is measured using the measuring device. The tip of the blade should be in the subchondral bone 10 to 15 millimeters from the joint. Therefore, approximately 10 millimeters are subtracted from the measured length to give the length needed for the blade. The instruments used for the insertion of the PFNA blade are the fixation sleeve, the 11 millimeter cannulated drill bit, and the 11 millimeter cannulated reamer. The drill sleeve is carefully removed without changing the position of the guide wire. The lateral cortex always has to be opened separately using the 11 millimeter cannulated drill bit. The drill bit is pushed over the guide wire. Drilling is continued to the stop. Then the drill is carefully removed. The chosen length of the blade is set on the 11 millimeter cannulated reamer. The cannulated reamer is now slid over the guide wire and reaming is begun. The fixation sleeve prevents reaming any farther. In elderly patients, it may not be necessary to use the cannulated reamer to prepare the blade insertion because of inferior bone quality. The hexagonal tip of the inserter is introduced into the appropriate slot. The PFNA blade is supplied locked. To unlock the blade and fix the inserter to the blade,
Then one of the most important thing is the drill which is used is not of the same diameter everywhere. At laterally it is 11 mm, but at the apex it is very less cutting. The size of the helical blade is much bigger than the drill. So in osteoporotic bone, even they say don't use the drill at all. Just outer side 11 mm and you hammer this in. This is a rotating, helical blade goes on rotating and it compacts the bone inside. So basically this implant never takes out the bone, it compacts it in, and that's why the fixation is good. Second thing is this is not round. Again, like DHS, this has one side is flat, so it acts as a derotation. So extra additional derotation screw is not required, and this big diameter compacts the bone and holds it very nicely inside.
the inserter is turned anti-clockwise until it stops. The inserter must not be tightened too firmly.
So now,
Now
that
the
is the
blade
rotating.
rotates freely. This rotation is essential for the insertion of the PFNA blade. The blade connected to the inserter is slid over the guide wire and through the protection sleeve. Because of the shape of the PFNA blade, it must be aligned with the protection sleeve for insertion. At the same time,
in
the
one
button on
direction
the
it will go
protection
in.
sleeve must be pressed. The blade is manually introduced into the femoral head as far as possible. Using light hammer blows, it's further inserted to the stop. The inserter has to click into the protection sleeve. Unnecessary force must not be used when introducing the PFNA
This much
blade. The
compression you
position
will
of the
get
blade is
immediately.
checked under image intensification in both planes. The PFNA blade is now locked by turning the inserter clockwise to the stop. Locking is verified intraoperatively under image intensification. If the gap is closed, the PFNA blade is locked. The button on the protection sleeve is pressed to
If you
remove
want
the
additional
inserter.
compression also you can do it out
The
after.
guide wire is removed and disposed of. The protection sleeve and the buttress nut are released and removed by pressing the button on the clamp device of the aiming arm. Dynamic and the 4.0 millimeter trocar, all version of the drill sleeve assembly through the static locking hole, the length of the required locking bolts. To loosen the connecting screw and the insertion handle is removed. The following instruments are needed. The extraction screw for the PFNA blade.
So basically, the principles are very important here again. And the screw once goes in, the way I said, it cannot rotate, so derotation occurs. once you compress this, this also gets locked. So the rotating blade becomes a single assembly, and this is a dynamic collapse can occur, and the static or a dynamic screw you can use. Nowadays, short PIPN is used only in very stable, otherwise always use a long. When you are using short, it is not having any side specific. Long one, all are right or left specific because bow is given to them. I think that's fine.
Can you hear me? Okay, with permission of Dr. Umesh, I want to show just one slide. This is a very important slide by AO. It emphasizes why you should countersink a lag screw. So if you don't countersink a lag screw, if you see the one on the left, you are putting forces on the cortex and you may fracture the cortex. Now, when we use a lag screw, commonly we are using it for a short oblique or even a spiral fracture. It's not as elegantly as the bone, present as the bone model. So you may have very less space between the tip of the fracture and where you're passing the lag screw. So if you don't countersink, this is what can happen. So this should be a very important take-home message from this course. So this video is all about the proximal humerus interlocking plate. And this is something a little new, something way advanced. And I was surprised how this thing came here for the pre-basic course. But since it is there, you can all watch the video. I'm going to leave you watching the video. I'm going to watch the video with you because the video is beautiful. It's a long video. Just enjoy it like a movie. But before the video starts, I just want to tell you a few things as to why this came about. And what was the reason that they started with this? They researched and started with a Philos plate. So, like I said, there are certain principles in this plate which I will just tell you. And you watch the video and you'll find out yourself. So first of all, the screws are locking. So this came about by thinking about the bone quality. Proximal humerus fractures, as you know, are not so common in young people, of course simple falls, but more common in the elderly people. It's kind of a fragility fracture, osteoporosis, therefore locking, number one. This has many principles. The construct of the plate also has tiny holes where you can suture the rotator cuff. This is perhaps the only fracture where one has to strictly maintain function, otherwise there is a loss of movement of the shoulder joint, so you have to take bites into the rotator cuff. It's all described here. And suture it, so you need place to suture it. So you can't just put it through the locking hole or the screw hole. So there are small little holes provided to suture the rotator cuff. That's another principle. That's an anchoring principle. The third thing is, if you remember, I told you about trabecular bone. This is where we orthopedic surgeons come into play. So there is something called as a support screw system in this plate. So the screws are directed in such a way that they mimic the trabeculae of the proximal humerus. So they are just locked into place and they provide structural support to the humerus. So one of the screw is called the Calcar screw. That's also seen over here. And lastly, of course, you have a nice long slot in the screw. That also will be shown here, where you can actually use a compression screw, a normal cortical compression screws. So these are a few principles regarding the Philos, and now enjoy the video.
System, or Philos. The proximal portion of the plate has 9 holes. The most proximal holes at level A are parallel to one another and angle the screws slightly upwards. At the next level, B, the holes are staggered and the screws converge in the head of the humerus. At level C, the holes are inclined upwards and the screws diverge in the head of the humerus. The next hole at level D is an LCP combination hole which is inclined slightly upwards. This inclination, as well as the anatomical shape of the plate, makes the screw ascend into the head of the humerus. At level E, the holes diverge slightly and incline upwards to provide the screws with purchase in the opposite calcar region. A variety of screw combinations in the proximal part of the plate is possible. The most proximal hole in the shaft portion of the plate allows either conventional 3.5 millimeter screws or locking head screws to be inserted. By using a conventional 3.5 millimeter screw in the longer portion of the hole, vertical alignment of the plate is possible. Further distal holes are of the LCP combination type. For the fixation of the tendons of the supraspinatus, the infraspinatus, and the subscapularis to the plate by means of sutures, there are 10 2-millimeter suture holes. There are 2 types of screws: compression screws and locking head screws. The standard compression screw can have a full thread or a partial thread. A screw with a partial thread is called a shaft screw. The 3.5 millimeter screw has a head diameter of 6 millimeters. In the fully threaded version, the diameter of the thread is 3.5 millimeters and the core 2.5 millimeters, while in the shaft screw, the diameter of the shaft and the thread is 3.5 millimeters and the core 2.5 millimeters. A self-tapping version of the 3.5 millimeter compression screw with full thread is also available. It can be recognized by its 3 tapping flutes. In this exercise, a self-tapping 3.5 millimeter compression screw will be used. Locking head screws have conical threaded heads. The self-tapping locking head screw has tapping flutes and a rounded tip. Self-drilling, self-tapping locking head screws are characterized by a pointed drill tip and tapping flutes. The self-drilling version is used mainly as a monocortical screw in the diaphysial region. The unique combination holes shown here in a 3.5 LCP allow this plate to be used as a standard compression plate, as a locked internal fixator, or as a system combining both fixation concepts. The combination hole accommodates compression screws. They should be placed only in the unthreaded portion of the combination hole, the so-called dynamic compression unit. Wide angulation of the compression screw is possible. Compression screws can be used to fix the plate onto the bone, or to achieve dynamic compression of the fracture when eccentrically inserted and tightened. The threadless locking head screws are used only in combination with fixation. Proximal humerus fractures. The affected arm is freely mobile, washed, and draped. The appropriate surgical approach is anterior access in the deltoid pectoral sulcus. The use of the Phelos plate on a 1-1 A3 subcapital upper arm fracture, according to the AO classification, is shown. The Phelos aiming device is attached to the plate with a hexagonal screwdriver. If sutures are to be used, it's recommended to pass them through the suture holes before attaching the aiming device. For the distal fixation with self-tapping 3.5 millimeter compression screws, the 2.5 millimeter drill bit, the 3.5 universal drill guide, the depth gauge, and the hexagonal screwdriver are needed. For the proximal fixation with 3.5 millimeter locking head screws, the centering sleeve for the Philos aiming device, the drill sleeve, the centering sleeve for K-wires, the 2.8 millimeter LCP drill bit with length markings and the hexagonal screwdriver shaft with the 1.5 Newton meter torque limiting attachment are needed. The torque limiting attachment ensures optimal tightening torque of the head of the screw in the threaded hole of the plate. The anatomical shape of the plate allows an indirect reduction of the fracture. For this, the plate is placed towards the head of the humerus. The plate is positioned 5 to 10 millimeters dorsal to the posterior delimitation of the intertubercular sulcus, and usually 8 millimeters caudal to the upper edge of the greater tubercle. The correct position is found by placing a K-wire through the proximal guide hole of the aiming device. The K-wire should be aimed at the level of the joint surface. Through the dynamic part of the long hole, both cortices are drilled using the universal drill guide in the neutral position and the 2.5 millimeter drill bit. The length for the 3.5 millimeter Cortex screw is determined with the depth gauge. If a non-self-tapping screw is to be used, a thread has to be tapped. By tightening the screw, the humeral shaft, which has been displaced medially, is drawn onto the plate until the reduction is completed. In some cases, a sharp hook is needed to achieve a complete reduction. The vertical position of the plate is adjusted before the screw is fully tightened. In this exercise, locking head screws at levels A, B, and D will be used. The K-wire can be removed. To ensure correct axial positioning of the screws in the proximal portion of the plate, the centering sleeve and the drill sleeve must be used. The 2.8 millimeter LCP drill bit with length markings is used to drill the hole. If this drill bit is not available, or if there is any uncertainty about the depth of the drilling, it's recommended to use the depth gauge. The length markings on the drill bit indicate the length of the screw to be used. The drill bit and the drill sleeve are removed. A self-tapping 3.5 millimeter locking head screw is now inserted. When using the air drive, it is essential to use the torque limiting attachment with screwdriver shaft. The centering sleeve is removed. As an alternative way of measuring the screw length, the centering sleeve for K-wires and a 1.6 millimeter, 150 millimeter long K-wire could be used in addition. The tip of the K-wire should be located in subchondral bone. The length of the screw now is determined by sliding the direct Philos measuring device over the K-wire. The direct measuring device, the K-wire, and the centering sleeve for K-wires can be removed. The hole is drilled to the correct depth with the 2.8 millimeter LCP drill bit. After removing the drill sleeve, the appropriate 3.5 millimeter locking head screw is inserted. After all the required holes are filled, the proximal fixation of the plate is completed. For the remaining shaft holes, the universal drill guide is used either in a neutral or in a compression position. For increased stability in osteoporotic bone, screws might have to be placed at different angles to the shaft. Both cortices are drilled with the 2.5 millimeter drill bit. The length is determined with the depth gauge, and a 3.5 millimeter self-tapping Cortex screw is inserted. The process is repeated distally. The Philos aiming device is removed. The fixation of the plate is now complete. X-rays taken directly after the operation show the clinical result. On a multifragmentary proximal humerus fracture, it's now shown how the tubercles can be fixed to the plate with holding sutures to secure the reduction and to neutralize the muscular traction of the rotator cuff. The black rubber represents the insertion of the infraspinatus, the supraspinatus, and the subscapularis. Sutures have been attached to the tendinous insertions of these muscles. The fracture lines in this four-fragment fracture separate the tuberculum minor, the tuberculum major, and the head fragment from the humeral shaft. The fracture is reduced with the help of a bone spreader and a periosteal elevator. A pull on the sutures attached to the muscle tendon and the sharp hook may help to achieve the required reduction. The reduction is held in position temporarily with K-wires. These wires have to be placed so that they do not hinder the later positioning of the plate. The sutures are passed through the suture holes of the plate. After attaching the Philos aiming device, the plate is slid down to the bone. The plate is now fixed to the bone. The temporary K-wires as well as the aiming device can be removed. To neutralize the muscular traction of the rotor cuff, the sutures are secured to the plate. The fixation of the multifragment fracture is now complete. X-rays taken directly after the operation show the clinical outcome.
So that was basically how you fix a Philos. I think we'll go to the last video for the day. But if there's any question that you want to ask about the Philos, I can take that in the meantime. Any questions for the Philos? So looks like the video was very clear. Thank you.
Junction is reduced and held by a forceps. The joint block is reduced towards These are the x-rays of an 83-year-old woman suffering from severe osteoporosis with multiple trauma, including this distal intra-articular C3 fracture of the much shortened radius with dislocation of the ulna. Emergency external stabilization was performed with a wrist bridging fixator with unsatisfactory positioning of the fracture. After stabilization of the shock state, definitive treatment of this fracture is carried out on the 7th day with the fixator still in place. A traditional volar approach, not touching the contused soft tissue regions, is performed. The approach is made between the flexor tendons and the ulnar neurovascular bundle. An inserted bone lever retracts the median nerve and allows an adequate approach to the pronator quadratus muscle. This muscle is incised radially and sharply dissected from the bone. The fractured distal radius is now visible. The clamps of the external fixator are loosened to allow indirect reduction. The actual shortening is corrected through distraction. The intermediate fragment on the ulnar side of the metadiaphyseal junction is reduced and held by a forceps. The joint block is reduced towards the distal radial shaft with approximately the correct length. Preliminary stabilization is provided by 2 K-wires. This is the simplified fracture model, with the joint block split at the sagittal level and a segmentary metaphyseal comminuted fracture zone. For the stabilization of the fracture, the following implants are available. A 5-hole right-angled 3.5 LCT plate with the appropriate screws, 1 cancellous bone screw for compression of the joint block, 1 conventional cortex screw for preliminary fixation of the plate onto the distal shaft, 2 green self-tapping locking head screws for the joint block, and 2 blue self-drilling, self-tapping locking head screws for the radial shaft. Chosen from the small fragment set are left to right a 2.5 millimeter drill bit, a 3.5 millimeter tap for cortex screws, a 4 millimeter tap for cancellous bone screws and the handle, the 3.5 universal drill guide, the depth gauge, and the hexagonal screwdriver. From the LCP set, the choice is left to right. The threaded LCP drill guide, the 2.8 millimeter LCP drill bit with length markings, and the torque limiting attachment fitted onto the screwdriver shaft, which can be connected to both the air drive and the handle. On the model, in contrast to the clinical case, first the joint block is reduced and initially fixed with a K-wire. The wire should be inserted as far as possible in the dorsal direction to allow the palmar distal placement of the cancellous bone lag screw that has to be inserted. This prevents interference with the planned locking head plate screws in the joint block. Drilling with the 2.5 millimeter drill bit. The length is measured. Tapping is done with the 4 millimeter tap for cancellous bone screws. The 4 millimeter cancellous bone screw with a short thread is inserted to function as a lag screw. The 5-hole 3.5 LCT plate, which is fitted with a threaded drill guide as holder, is placed on the bone.
Here is the same step with the 83-year-old patient. The joint block serves as reference for the longitudinal alignment of the plate. The distal end of the plate should come to rest about 3 to 5 millimeters proximal to the joint cavity. The plate is primarily fixed onto the distal shaft with a conventional Cortex screw. The hole for this screw is drilled with the 2.5 millimeter drill bit. The length is measured. Tapping with the 3.5 millimeter tap for Cortex screws. The selected 3.5 millimeter Cortex screw is inserted. The threaded drill guide is removed and the joint block is repositioned onto the distal end of the plate. Care has to be taken to ensure that the joint block lies close to the plate to achieve a correct axis in the lateral radiation path. The drill guide is screwed into the transverse T-arm of the plate. These threaded holes in the transverse T-arm are not at right angles to the surface of the plate, but are tilted at an angle of 86 degrees in the proximal direction to avoid, as far as possible, any perforation of the distal radial surface of the joint by the screws. The holes are drilled with the 2.8 millimeter LCP drill bit. If the contralateral cortex is drilled carefully, the corresponding length of the screw can be read off the drill. The drill guide is removed. To prevent damage to the locking head screws or to the conical thread in the plate, only the torque limiting attachment or the torque screwdriver may be used. A damaged hexagonal screwdriver must not be used. A green self-tapping locking head screw is screwed in with the air drive fitted with the torque limiting attachment. The screw must not be fully screwed in with the air drive. The final turns must be made with the manual screwdriver fitted with the torque limiting attachment until a click is heard. Using the identical technique, another locking head screw is inserted into the radial portion. In the presence of pronounced osteoporosis, as in this 83-year-old patient, it's worthwhile to insert 3 screws into the joint block. After the cortex screw in the distal portion of the shaft has been slightly loosened, a fine reduction of the fracture zone can still be carried out. In this way, it's still possible to correct, in particular, a tilting of the radius or the ulna. The large reduction forceps is removed and the internal fixation is completed by inserting 2 monocortical self-drilling, self-tapping locking head screws in the distal portion of the shaft. These screws must be inserted without pre-drilling, as far as possible in the center of the threaded hole and at right angles to the surface of the plate. Alternatively, this hole can be pre-drilled monocortically with the
So normally we expose it, I personally do it with a volar approach, which is just lateral to the flexor digitorum longus, and once the flexor digitorum longus, the anterior sheath is cut, you retract it, you will protect the radial artery, which is, and it is taken laterally. And in this particular case, now what we will do is, we'll initially fix this distal intra-articular fracture with a lag screw. for that you need an additional lateral small incision. 3.5 चा पाहिजे मला आता. So we have just seen that when you want to achieve a compression, interfragmentary compression, we would use first a glide hole, that is a larger hole, using a 3.5 mm drill bit. Cortex because I don't have a feel of medullary canal here, this being a sawbone. So after the glide hole has been drilled, so my 2.5 sleeve goes in, and then I drill with a 2.5 hole or 2.7 mm drill bit. Then I use a depth gauge. This is 38. Then you would use a tap normally, because we are not using tap here because it's right now not available. And in osteoporotic bones, in elderly, is it there? The tap is there? Okay. धरलंस ना तू? धरलंस ना? मी टाइप हां. रिडक्शन जायला लागलं काय? धरलंय ना? आला का बाहेर? नाही. बस. काय हल्लं का काय? ओके. डिस्प्ले झालंय का? ओके. बस. Okay. So normally what you would do is you would cut the pronator quadratus towards the radial border and reflect the whole pronator quadratus towards the ulnar side, and then you would center, you would clean the fracture, that you will ask the assistant to give traction. You would use a lever or a spike so that the volarly displaced the distal fragment, you would jack it open, and once you achieve a reduction, you can usually maintain it with a small K wire pass from the radial styloid into the, which is going medially, ending up into the proximal shaft. So then you would position the plate, and then you would use a first cortical screw to fix the plate to the bone. So once you fix the plate to the bone, it gives it automatically, the distal fragment is buttressed. 3 the thing is that this एक minute plate दे this particular plate has a oblong hole here. So many a times what happens is the size of the distal fragment varies. So what you can do is use this oblong hole first, so that because the hole is oblong, if your plate position you want to change, you would loosen the cortical screw and take the plate more distal or proximal. So these things are there, but if we are not aware of them, we don't use them. I don't need to change this here, no? Drill sleeve madna karayala pahiye. आले का बाहेर काय कळलंच नाही. Tap, tap, tap. The screws provided to me are self-tapping, so I don't have to tap. 16. Thereafter, you would fix then you would take a check X-ray, see in AP and lateral view. Remember, still you have a chance, because you can loosen the cortical screw and adjust it, see that your plate is exactly on the bone. Okay. Locking sleeve. तटणार का त्याला दे? Otherwise मागे पुढे करू की. Still we have a chance, no? जाणार का? ठीक है. So we are using a 2.8 mm drill. The interfragmentary screw is coming in the way, so we will take the plates a little proximal. Bas. If this was a variable angle plate, we could have easily missed that. Now, another most important thing which I would like to emphasize upon is always keep these screws sub-bicortical. Means we know what is monocortical, we know what is bicortical. In distal end of radius, you should use, and in proximal humerus also, you should use sub-bicortical, means they should not come out of the opposite cortex at all. That is to, I just want any resident to answer me why you want to keep them short. Because the rupture of extensor tendons is it's a big possibility. You heard the click, I suppose. Click. Okay. So we can pass another screw also. Few people encourage, if you are using a cortical screw, in order to have a better hold, they would advise you to pass in a different direction. Instead of pass, if I am using a cortical screw here, instead of passing it like this, pass it in this fashion to increase the span of fixation. Usually we find that these patients would have problem getting complete supination. If you have observed patients for who have undergone volar locking plate, so I personally give above elbow slab in complete supination. In your patients, you try it, they don't, and keep it for 3 weeks, they will never complain of inability to supinate. Any questions we can take? Sir. You can elevate it if required. Here the insertion is very broad. So in order to avoid the tendons, you would split the tendons and go in between.
So any question? Hello?
So we come to the end.
So any question regarding the workshops? So it's time to close the meeting. So certain points I like to elaborate. We have sent the feedback forms to all of you on your group. So please fill the form and send it, because it's important. It's needed for us to improve the further programs, and also needed for AO people and our university. Then second thing, you will be getting certificate. The certificates will be of 2 types. One is of AO trauma in their prescribed form, and second is for of the MMC credit hours. I thank you, Dr. Uddhav Patil sir. He is a MMC observer, and also like to tell you that usually MCI takes money from us, but for this program we tried. We have got 50,000 cash from the MCI. Also, D.Y. Patil University has also funded us to for this program. And also like to thank you again all the delegates, especially students from various parts, and I also like to thank the consultants and my friends and my faculty colleagues. And special thanks to resident Dr. Gunjan and AO person Mr. Sriram. Here I declare the program is over. You can now proceed to your team and you can go. The certificates will be delivered downstairs only.